Hello, Medicos. Good day to all of you. This is Dr. BK for you, and today's topic on head and neck will be on the paranasal sinuses. So, in the last session, I have actually discussed about the nasal cavity, and with respect to the nasal cavity, I have discussed about the nasal septum, that is the bones forming the nasal septum, and then the lateral wall of the nasal cavity. So, more importantly, on the lateral wall of the nasal cavity, so you should know the structures opening into the various meatuses of the nose, that is the inferior, middle, and the superior meatus. Now, in today's session, I will be talking about the paranasal air sinuses. So, mainly a short introduction about this paranasal air sinuses. So, followed by that, I will be discussing the paranasal air sinuses, its situation, relations, blood supply, dimensions, and most importantly, the clinical aspects of the paranasal air sinuses. So, mainly there are four sinuses which is present. They are the frontal sinus, ethmoidal sinus, maxillary sinus, and then the sphenoidal sinus. So, a representation of the sinuses you are able to see in this picture. Now, what are these air sinuses, paranasal air sinuses? They are present within the bones around the nasal cavity. Okay, so air spaces within the bones situated around the nasal cavity. Okay, so that is why these bones are also called as the pneumatic bones, because they contain this cavity. They are called as the pneumatic bones. Okay, so as I told you, they are situated around the bones of the nasal cavity, and they all open into the lateral wall of the nose. So their secretions are mainly drained into the lateral wall of the nose. That is one thing. At the same time, if you look or examine carefully, you can see they are also mostly concentrated around the medial wall of the orbit. Okay, so they are also concentrated around the medial wall and to some extent on the roof and floor of the orbit. Okay, so mainly they are air cavity, as I told you. They are lined by mucous membrane, and the lining epithelium is the ciliated columnar epithelium, so which is the characteristic epithelium of the respiratory passage. Okay, so now how actually they are developed? They are actually developed as the outgrowths or the diverticula from the nasal cavity. Okay, so outgrowth or diverticula from the nasal cavity. Okay, that is, if you see the two nasal pits, okay, so these two nasal pits, what happens? They will actually deepen inside, and they will actually uh, what do you call widen to form the nasal cavity. Now, from these nasal primitive nasal sac like cavity, you see extensions which is going posteriorly and laterally, and they mainly form the paranasal air sinuses. So you can consider them as the extensions from the nasal cavity itself. So all the sinuses are actually present during birth itself, but they are very rudimentary. That means they are not well developed. They are at a very primitive stage. Their sizes are very minimal, except the frontal sinus, which appears only after 2 to 3 years of the age. Okay, and all the sinuses are actually paired. We have a pair of frontal sinus, maxillary sinus, sphenoidal air sinus, and you have ethmoidal sinus on either side. But again, each sinus is divided into three groups. With respect to ethmoidal sinus, alone. So that is, they are divided into anterior, middle and posterior group of sinuses. So with a short introduction, we will actually pass on to the frontal sinus. So the frontal sinus, the name itself is because it is present within the frontal bone, and it is the second largest of all the sinus. Okay, so it is situated in the squamous part of the temporal bone. Okay, sorry, squamous part of the frontal bone. So frontal bone has got a squamous part, and this is, you are able to see the orbital part of the frontal bone. So mainly these sinuses, how actually, even though they are extensions of the nasal cavity, I told you, they expand at the expense of the diplo of the skull, because you know most of the bones of the skull, they have an inner table and outer table, and between you have the diploic tissue, so they will be drained by the diploic veins. So they actually go and occupy this diploic part of the bones. So roughly they are triangular and present at the medial end of the superciliary arch. Okay, so they are present behind the medial end of the superciliary arch, and as I told you, they are roughly triangular, and their dimensions are mainly, you can see here, it is extending superiorly and also it is extending posteriorly into the orbit. Okay, mainly into the roof of the orbit. Okay, so that is the frontal sinus, roughly triangular and asymmetrical. Okay, they are both the sinuses on either side, they don't have a definitive shape and size. Okay, and as I told you, it extends superiorly into the skull itself and posteriorly into the roof of the orbit. And your obliquity of your forehead, so your forehead has an oblique direction, that is mainly because of this frontal sinus. Okay, so it is almost 3 centimeters in height, and 2.5 centimeters is the transverse width, and antero-posteriorly it is 1.5 centimeters. Okay, antero-posteriorly from front to behind it is 1.5 centimeters. So these are the rough dimensions of the frontal sinus. Now, where actually this frontal sinus communicates into the lateral wall of the nasal cavity. So that is the into the middle meatus. Okay, so you have below the bulla ethmoidalis the hiatus semilunaris. So a moon-shaped sulcus, half moon-shaped sulcus, which is called as the hiatus semilunaris. In the anterior part, what happens? Hiatus semilunaris continues as the infundibulum. So that receives the frontal sinus directly or through a duct, which is actually called as the frontonasal duct. So all these things I have already discussed in the lateral wall of the nasal cavity. So mainly it is supplied by the supraorbital vessels and nerves. Okay, so supraorbital nerve is actually a branch of the frontal nerve, which is one of the division of the ophthalmic division of the trigeminal nerve. So ophthalmic nerve divides into frontal, lacrimal and then nasociliary. So the frontal nerve finally divides into medial supratrochlear and lateral supraorbital nerve. So this supraorbital nerve also supplies the frontal sinus. Same way the supraorbital artery, which is also a branch from the ophthalmic artery. So mainly they drain into the submandibular lymph nodes. So your frontal sinus drains into the submandibular lymph nodes. Maxillary sinus drains into your submandibular lymph nodes. Even your anterior and middle ethmoidal sinus drains into the submandibular lymph nodes. So the submandibular lymph nodes is actually drains a very vast area. Okay, so your medial angle of the eye, lateral part of the nose, lateral part of your lips, or including this all these paranasal sinuses is all drained by the, and also mainly your sides of the tongue. All this is drained by your submandibular lymph nodes. Now, surface marking, you make a point on the nasion, okay, root of the nose, okay, and then you make another point 3 centimeters above, that is the vertical height of the sinus. Then you make an other point at the supraorbital margin at the junction of medial 1/3 and lateral 2/3, and you connect all these 3 points. Then that will give the surface projection of the frontal sinus. Okay, so that is about the frontal sinus, its situation and relations, and the blood supply and the lymphatic drainage. So next, coming to the ethmoidal sinus. They are not as a single sinus, but they are a group of sinus which is present on the lateral wall of the nasal cavity or on the medial wall of the orbit. So they are present between the lateral wall of nasal cavity and medial wall of the orbit, which you are able to see here. Okay, so they are contained within the labyrinth of ethmoid bone. So the two lateral mass of the ethmoid bone is called as the labyrinth of ethmoid bone, and in between that you are seeing is the perpendicular plate of the perpendicular plate of ethmoid bone. This is your inferior nasal concha, and that should be your floor of the nasal cavity or roof of the oral cavity, mainly formed by the hard palate. So labyrinth of ethmoid bone, again I have discussed in my previous class on the lateral wall of the nasal cavity, which contains air filled spaces. So that is why the term itself labyrinth, interconnecting spaces. Okay, so as I told you, between the medial wall of the orbit and the lateral wall of the nasal cavity, they are actually present as 3 groups: anterior group of sinus or anterior ethmoidal sinus, followed by the middle group of sinus, middle ethmoidal sinus, and then you have the posterior ethmoidal sinus. So from anterior to posterior, you are able to see that anterior, middle, and posterior group. So that should be your medial wall of the orbit and ethmoid, and it will be completed by your lacrimal. Okay, so surrounding bones, frontal process of maxilla, then you have the lacrimal bone, and behind you have the medial pterygoid plate, perpendicular plate of the palatine bone also. So mainly anterior ethmoidal sinus are actually 3 to 7 in number, and they drain into the anterior part of hiatus semilunaris. Okay, so again this is the hiatus semilunaris. So in the anterior part, which receives the opening of anterior ethmoidal sinus. Okay, the next is the supplied by the anterior ethmoidal vessels and nerves. So they are again branches of the nasociliary nerve, anterior ethmoidal nerve, which passes through the canal of the same name, anterior ethmoidal canal. So next, coming to the middle ethmoidal sinus, they are 1 to 3 in number, and they form a bulge on the lateral wall, which is called as the bulla ethmoidalis. Okay, and the sinuses itself opens on the bulla ethmoidalis or just below it. Okay, that is again which is seen in the middle meatus of the nose. So below the middle nasal concha, you see the middle meatus. So first we saw the anterior ethmoidal sinus, which opens into the anterior part of the hiatus semilunaris. That is the hiatus semilunaris. Middle ethmoidal sinus, they actually form the bulge which is called as the bulla ethmoidalis, and they open with the opening on the bulla or immediately below it into the hiatus semilunaris. Okay. The next is it is supplied by the posterior ethmoidal vessels and nerves. Coming to the posterior ethmoidal sinus, you are able to see here 1 to 11 in number, and they open into the superior meatus, below the superior nasal concha. So to remind you again, this superior and middle nasal concha are again part of the ethmoid bone itself. They are actually projections, medial projections of the labyrinth of the ethmoid bone. So posterior ethmoidal sinus are actually 1 to 11 in number and communicates with the lateral wall of the nasal cavity via the superior meatus. They are again supplied by the posterior ethmoidal vessels and nerves. So here you are able to see the posterior group of the ethmoidal sinus. So there you are able to see the nasociliary nerve, which gives anterior ethmoidal nerve, and that is the posterior ethmoidal nerve. So here you are able to see the ethmoidal sinus. Okay, so anterior, middle and posterior group. So anterior will be supplied by the anterior ethmoidal nerve, middle and posterior will be supplied by the posterior ethmoidal nerve. They are branches of the nasociliary nerve. This is your optic nerve and that is your frontal branch, which is again nasolacrimal. Nasolacrimal is again one of the branches of the ophthalmic division of trigeminal nerve. The other one being the lacrimal and frontal. Okay. So again the lymphatics drain into submandibular lymph nodes and posterior ethmoidal sinus may drain into the retropharyngeal nodes. So next, coming to the maxillary hair sinus. This is actually the largest of the paranasal sinuses. The second largest I have told you the frontal, but the first largest sinus is the maxillary sinus, which is situated within the body of the maxilla. The other name, it is also called as the antrum of Highmore. Okay, so they want the name, alternative name is the antrum of Highmore, maxillary air sinus. So as I told you, it is present within the body of the maxilla as a large air space which is lined by the mucous membrane. Okay, it is lined by the mucous membrane. So if you look at the shape, it is roughly pyramidal in shape, and you have the apex which is pointing laterally and the base. So that is the apex and the base which is actually pointing medially. Not pointing, base cannot be a pointed end, only the apex can be a pointed end. So base is related to the lateral wall of the nasal cavity. So here you are able to see the within the maxilla, that is the maxillary air sinus, and here the base part of the maxillary air sinus you are able to see, which has the opening at a higher end. Okay, so the base is directed towards the lateral wall of the nasal cavity. So that is should be the nasal septum or the medial wall, lateral wall of the nasal cavity, and you see a very large base. Whereas the apex is actually directed towards the zygomatic process of the maxilla, okay, which is pointing laterally. Apex is directed towards the zygomatic process of maxilla. So mainly it has a dimensions of vertical through 3.5 centimeters, transverse is 2.5 centimeters, and antero-posterior is also 3.5 centimeters. So as I told you, it is the largest of the air sinuses. So the hiatus is at a higher level, as I told you, is a large opening at the base, and it is at a more disadvantageous position, because if that all there is a collection of pus, then what happens is they tend to get collected at the lower end due to the gravity. So natural drainage is a bit difficult. Now I showed you a large opening in the previous slide, but in the recent state, so mostly in the living state, or for that matter in an articulated skull, that opening is actually reduced to a very small one by the surrounding bones. Okay, so it is reduced mainly from below by the inferior nasal concha, from below by the inferior nasal concha, and from above by the bulla ethmoidalis. Okay, so the uncinate process, no, of the ethmoid bone from above. which also contains the bulla ethmoidalis. From above it reduces, from below the inferior nasal concha it reduces, and then you have the lacrimal bone and the perpendicular plate of palatine bone. So from behind you see the perpendicular plate of palatine bone, and in front the descending process of the lacrimal bone. So these four bones reduces the opening into a very small one in the hiatus of semilunaris. So mainly it is the uncinate process of ethmoid, inferior nasal concha from below. This is uncinate process from above, descending process of lacrimal bone in the front, and the perpendicular plate of palatine bone from behind. They reduce the maxillary hiatus, and you see only a small opening which is near to the roof. Okay, so mainly it is above the uncinate process nearer to the roof. Usually you have two openings, one is above the uncinate process and other one is below the uncinate process. But again, in the recent state, that is in the living state, the lower opening is actually closed by a mucus plug. So only to the above opening the drainage takes place, and as I told you, it is in a disadvantageous position for the nasal drainage because the pus tends to collect only at the nearer to the floor because of the gravity. Now we will come to the other relations and walls. So roof is mainly formed by the orbital surface of maxilla. So that is nothing but the floor of the orbit, and the floor will be traversed by the infraorbital vessels and nerves, okay, which passes through the infraorbital canal. Floor is actually formed by the alveolar process of maxilla. So mainly the molars and premolar tooth, they actually make projections, especially what happens is when there is a spurt of growth. Usually it is not seen at birth, but once the what happens is this the tooth starts to appear, and slowly what happens is when these actually grow and they develop the permanent teeth, they make projections into the floor, especially the molar and the premolar tooth, and sometimes even the canine can make a projection into the floor of the maxillary sinus. So here you are able to see the roof. On the roof you are able to see the infraorbital vessels and nerves. So floor with these tooth you are able to see here. Then anterior wall, mainly it is related to the anterior superior alveolar vessels and nerves. Anterior superior alveolar vessels and nerves, they actually run inside a canal called as the canal sinusitis. Okay, so canal of sinus is actually which runs in a canal in the body of the maxilla. So they are related to the anterior superior alveolar vessels and nerves, that is the anterior wall. Okay, then it is also related to infraorbital plexus, because this infraorbital nerve, what happens, they form a plexus here, the face immediately below the infraorbital margin. Then coming to the posterior wall, so it is mainly formed by the body of maxilla, again the maxillary tuberosity. Here it is pierced by the posterior superior alveolar vessels and nerves. Pierced by the posterior superior alveolar vessels and nerves, and the posterior wall also forms the anterior boundary of the infratemporal fossa. Anterior boundary of infratemporal fossa. Okay, so roof related to the floor of the orbit, floor related to the alveolar process, posterior wall anterior boundary of infratemporal fossa, anterior wall related to infraorbital plexus of vessels and nerves. So opening into the hiatus semilunaris in the middle meatus of the nose, posterior part of the hiatus semilunaris. Okay, so that is the opening which you are able to see nearer to the roof but not nearer to the floor. So it is supplied by the anterior, middle and posterior superior alveolar vessels and nerves. Blood supply and nerve supply, and drainage is into the submandibular lymph nodes. Lymphatic drainage is into the submandibular lymph nodes. So the blood supply to the maxillary air sinus is again by the anterior superior and the posterior superior alveolar vessels and nerves. They are all branches from the maxillary artery. Anterior superior will be given by the infraorbital when it is running in the infraorbital canal. So this is the posterior superior alveolar vessels and nerves. So lymphatics, as I told you, they are actually drained by the submandibular lymph nodes. So next, coming to the sphenoidal air sinus. So this is more posteriorly located within the body of the sphenoid, a pair of sinuses separated by a septum. Okay, they both the sinus, and again they are asymmetrical. So you are able to see the septum. First of all, it is not in the midline; it might be somewhat deviated, and the shape of the sinus is not symmetrical on either side. So, as I told you, it is in a more posterior plane behind the nasal cavity within the body of the sphenoid bone. So, dimensions 2 centimeters vertically, 1.5 centimeters transversely, and 2 centimeters is the antero-posterior measurement of the sphenoidal air sinus. So, posteriorly it can extend up to the foramen magnum and into the roof of the orbit. Okay, superiorly. So relations, mainly it is related above to the pituitary gland and the optic chiasma. So that is your body of sphenoid with the sphenoidal air sinuses on either side. So above it is related to the pituitary gland or the hypophysis cerebri and the optic chiasma. On either side it is related to the cavernous sinus with the internal carotid artery. Okay, on either side related to the cavernous sinus and the internal carotid artery. Okay, and below it will be actually related to the roof of the nasopharynx. So roof of the nasopharynx below. Okay, on either side, as I told you, it is related to the cavernous sinus. Behind, it will be related to the pons and medulla, and the bone, the sphenoid will be separated by the pons and medulla by the basilar plexus of veins. Okay, and anteriorly it's opening, that is the sphenoethmoidal recess. So here you are able to see the sphenoidal air sinus. Above, as I told you, it will be related to the pituitary gland, and above that optic chiasma. Posteriorly, that is the clivus, where your pons and medulla will be situated, and between this and the bone you have the basilar plexus of veins. This should be your posterior end of your nasal cavity. So this is your nasopharynx. So below it is related to the roof of the nasopharynx. Anteriorly it opens into a lateral wall of the nasal cavity, that is the sphenoethmoidal recess, which is in the supreme meatus. Sometimes also it might open into the superior meatus. So that is the sphenoidal air sinus opening into the supreme meatus. Okay, but sometimes it can also open into the superior meatus, mainly supplied by the posterior ethmoidal arteries and posterior ethmoidal nerves. So posterior ethmoidal vessels and nerves supply the sphenoidal air sinus, and the lymphatics drain into the retropharyngeal lymph nodes. Okay, so they mainly drain into the retropharyngeal lymph nodes. So that is about the relations, dimensions, blood supply and nerve supply of the sphenoidal air sinus. So far we have been discussing about these air sinuses. So what is the main functions of this paranasal air sinus? First thing, they reduce the weight of the skull, because certain bones, since they are filled with air cavity, they reduce the weight of the skull or facial skeleton. Then second one is they add a resonance to the voice. So you get a resonating note on your voice. It is mainly because of these air chambers which is present. Because even when the sound is produced from the larynx, which is called as the voice box, so that voice adding resonance or a vibration to the voice is mainly due to this paranasal air sinuses. So that is one function. Then the next function is it acts as air conditioning chambers. So the inspired air, what happens is since it is passing underneath the turbinate bones, the turbine force is created. Not only this, when the air naturally will also pass into these chambers, and because of that, the air is getting adding temperature or warmth and also humidity to the inspired air. Okay, so due to the suction in the nasal cavity, negative pressure in the nasal cavity, what happens? The air might enter into this paranasal sinuses and naturally they act as air conditioning chambers. Now, because of this, what happens is from the inspired air, naturally the infections are also more common in this paranasal air sinuses, responsible for the adult shape of the skull. So how the from the childlike face, what happens is adult face like this adult actually appearance of this face, because there is a growth in the facial skeleton. So first spurt of growth will occur around 7 years of age, mainly when the permanent tooth is actually erupting to that stage, and then during puberty you see a second spurt of growth. Okay, when these sinuses show two spurts of growth, as I told you. So frontal sinus usually is not seen at birth. Slowly it appears 2 to 3 years of age, and then only you can see the frontal sinus. So these are the main functions. So mainly gives adult shape to the facial skeleton, air chambers, adding resonance to voice and reduces the weight of the skull. So now coming to the clinical aspects, inflammation of the sinus is actually called as sinusitis. So what happens is the mucous membrane lining this becomes thick and starts producing secretions. So the inflammation that is called as the sinusitis, it might be of two types: acute sinusitis or chronic sinusitis. So chronic sinusitis might be when you have this condition for more than a month, it is called as the chronic sinusitis. So it might be due to secondary infections, bacterial infections, or secondary infections, what happens, which is present along the drainage passage. So symptoms most commonly is nasal congestion, blockage of nose, then discharge. Okay, so discharge you might have, mainly it might be yellowish or green color discharge. Mostly green color means it is due to the bacterial infection. Okay, so then pain and pressure in the face, mainly around the eyes and where all the sinuses are present. So pain and pressure you come across. And then headache is the most common symptom, especially when your frontal or sphenoidal air sinuses are involved. So frontal sinusitis, severe pain on the localized area. Okay, and the pain when you get up in the morning it starts, and up to noon the pain actually peaks, and after that slowly it subsides. So this is the characteristic pattern of the frontal sinusitis. It is also called as the office headache. Okay, most commonly referred as the office headache. And complications it might lead to, since here the frontal lobe is situated immediately above the orbital plate and behind the squamous part of the frontal bone, it might lead to frontal lobe abscess or orbital cellulitis. So you see inflammation, edema of the eyelids, proptosis, slight protrusion of the eyeball, the chemosis, and erythema. So your eye also starts, what happens, discharge from the eyes because your conjunctiva all might get inflamed. That is called as orbital cellulitis. The next commonly affected or the most commonly affected sinus is the maxillary sinus because of its position and because the natural drainage is not possible. Okay, so it is mainly secondary to rhinitis, so infections from the nose or from the floor carries of the tooth. So any what happens tooth decay might also spread into the sinus and it is secondary to the frontal and anterior ethmoidal sinus because these sinuses when they drain into the hiatus semilunaris naturally through their drainage these secretions infections what happens might settle in the maxillary air sinus. So it might be secondary to your frontal and anterior ethmoidal sinusitis. So pain is referred into the tooth, so into the orbit, floor of the orbit, apart from your pain over the face in the maxillary region. Okay. Now, if the infection is not receding and the pus tends to get collected, it is not draining by any administration of antibiotics, then what happens is the surgical drainage is the only procedure. Now, what happens? This is actually inflation of the sinus and irrigation. So you insert a catheter and then you inflate the opening. Okay, because the mucus might be clogged and mucus is actually what you call swollen, inflamed, and pus is getting clogged. So natural drainage is not possible. You inflate the opening and now the drainage is cleared. Okay, now if this is not possible, then what happens is if the next is antrostomy or antral puncture. So this is again carried out by approach through the inferior meatus of the nose. You make a hole, okay, through the maxillary sinus and then you drain. Okay, approach through the inferior nasal concha as I told you. The next procedure is the Caldwell-Luke procedure. So approaching the sinus from the anterior wall. So you make an opening in the anterior wall, mainly what happens in the region of canine fossa. Okay, so anterior approach through the canine fossa, you go and then what happens is you drain the maxillary air sinus. So carcinoma of the maxillary air sinus is also more common. So if the growth, what happens if it is going to proceed above, then it will invade the orbit and naturally might displace the eyeball, or below it might invade the roof of the mouth palate. You can see a swelling over the palate, bulge protruding into the palate, or sometimes it might invade into the nasal cavity leading to nasal blockage, obstruction and bleeding from the nose, which is called as the epistaxis. So these are the complications of the maxillary carcinoma, maxillary sinus carcinoma. Ethmoidal sinuses is again secondary, mainly from frontal it might occur. So medial part and bridge of the nose pain will be felt, and again since it is related to the medial wall of the eye, it might spread into the orbit, creating orbital sinusitis. So sphenoidal sinusitis is very rare and spread mainly from the posterior ethmoidal sinus. So in complications are, if the sinus is swollen, it might stretch the dura. So you might have pain, headache, again mainly the posterior part of the head. More complications, it might spread to the meninges as meningitis. And sometimes what happens, it might go and compress the pituitary gland or optic chiasma. Okay, so these are the some complications of the sphenoidal air sinus. So here mainly to see or to visualize the sinuses, a radiograph. This is the most common and simple procedure. So you take an X-ray of the skull and you are able to see here the frontal sinus, and then you are able to see the maxillary sinus, and here you are able to see the ethmoidal sinus, the medial wall of the orbit. These are your turbinate bones you are able to see here, and that is your nasal septum which is deflected. What most common view to view the sinus is the Waters view with the mouth open. So when your mouth is open, mainly what happens is you can see the spheroidal sinus. Okay, so mainly you will come across the spheroidal. To view the spheroidal sinus, mainly the Waters view is recommended. Okay, so that is your orbit, and that is your nasal cavity with the nasal septum, and this is your maxillary sinus. Okay, so here you are able to see the maxillary sinus and the frontal sinus. Okay, this is your nasal septum. Oh, this is actually called as Waters view with the mouth open, mainly to visualize the sphenoidal air sinus. The next view is actually the Caldwell's view with the X-ray beam or CR. Okay, the rays when they pass at an angle which is to the lateral angle of eye and the upper border of the external acoustic meatus. Then, so this Caldwell view is also to visualize the uh, maxillary air sinus. So here, the paranasal sinuses. So frontal sinus you are able to see, they are not at all symmetrical. Here you are able to see these spaces are the ethmoidal air sinus. So this should be your maxillary air sinus, and that is the large projection is the inferior nasal concha, and that is your nasal septum. Usually it is deflected or deviated, so there is a mild deviation in most of the cases. Okay, so the Waters view only mostly you can visualize the spheroidal air sinus. Okay, so other things, sagittal suture and behind lambdoid suture is also in the norma occipitalis, that also can be visualized here. So here you see the within the mastoid bone mastoid air cells, so that also can be visualized in the Caldwell's view. So with this I have completed the paranasal air sinuses, and thank you very much for your patient listening.